Thanks for joining today. We're going to go over what documents are needed in order to submit Repatha and Praluent authorizations. For these requests, there are three major pieces of information that we need. If you send in these three pieces of information, that's going to be good enough for 95+% of requests. So the first piece is the diagnosis. This drug is indicated for different reasons, and depending on which diagnosis you're going for, the information that you're going to need to send in is a little bit different. Of course, we need the cholesterol lab, and lastly, the statin history. Are they currently on a statin or are they not on a statin? And again, depending on what your answer is to that question, what you need to send in is a little bit different, and we'll discuss the nuances of this in detail coming up. The last two pieces are not really that relevant, diet and exercise statement and other drugs, and we'll discuss why that is coming up. The first major hurdle is the diagnosis. There are three indications for this drug: pre-existing cardiovascular disease, familial hypercholesterolemia, and primary hyperlipidemia. You're going to want to pick which one of these diagnoses you want to go for and then build your documentation around that. Typically, you're going to want to pick one, and they're actually listed in alphabetical order, but they're also listed in ease of approval. Cardiovascular disease being the easiest, second easiest being familial hypercholesterolemia, and lastly being primary hyperlipidemia, and of course even beyond that would be for just other indications that it would not be FDA approved for. The first of the indications are for patients with established cardiovascular disease. And a great question to ask yourself is, what exactly is established cardiovascular disease? And that is a great question. And the answer is, it's not as well defined as many, let's say, many insurance companies would like it to be. Below here are a list of things that are definitely considered to be established cardiovascular disease. And if your patient has one of these indications and it's documented, then you're going to have a knockout case. You're not going to have any problem, at least with the diagnosis section. What I will tell you, though, is that this is not an all-inclusive list of what would be considered established cardiovascular disease. And I can tell you from personal experience, because I've done at least 7,000 to 8,000 Repatha and I've done a lot of PCSK9 inhibitors. And I've taken many of these to like administrative law judges for determination on what exactly that definition is. And what I can tell you is that there are many other cardiovascular situations, or many of them, that we've been able to take to a judge, and they have ruled that it is established cardiovascular disease and would meet the definition. So what I would say is use your own judgment on what you would consider to be established cardiovascular disease. But know if you have one of these that is on this list here, you're going to have a very easy time with it as long as it's documented. Next, we have familial hypercholesterolemia. I had to rename this slide because familial hypercholesterolemia didn't fit, so I hope that does not bother you too much. This indication often people will struggle with, they'll have a big difficulty with. And the reason for that is that many insurers will use the Dutch lipid scoring system, and they will be quite unfair about it by requiring definite. And what will happen is that it's very difficult to score enough points to get to the 9 or whatever it is to achieve a score of definite unless you already have some kind of cardiovascular disease. And if you already have cardiovascular disease, then you can just use the previous slide in order to get it approved. So for the younger people that don't already have cardiovascular disease, they have to get an LDL of like 300 in order to get definite if that's their only issue. So what I would recommend to use is the MedPed criteria, which makes way more sense than the Dutch lipid as far as getting people diagnosed that are appropriate. Technically, anyone with over 190 is going to be a possible candidate for familial hypercholesterolemia. So to not get definite, until you hit an LDL of 300 is, I'm sorry, it's completely ridiculous. So what you can do is use this rubric here, and on the left is the age, and then there are varying total cholesterol scores that need to be met in order to qualify for the diagnosis, depending on who their nearest relative is. And what I also like is that it has general population. We had several people that were adopted, for example, years ago that were struggling to get Repatha approved because, well, we didn't know who their nearest relative was. So this makes way more sense. So all you would need to do for this is send the total cholesterol score and who the closest relative is, assuming that they are a definite match according to this rubric. And that should make it much simpler for you. Lastly, we have primary hyperlipidemia. And I don't have too much to say about this indication aside from it's best not to use it if at all possible. If the patient meets either the FH criteria or the cardiovascular disease criteria, it's much better to use that. The problem is primary hyperlipidemia is not super well defined, and you can run into a lot of problems going with this indication. Sort of a diagnosis of exclusion, so that is part of the problem. There's not really a set criteria of who is considered to have primary hyperlipidemia, and that's why generally you want to avoid it if all possible. But if you are going to go down this route, make sure it's clearly documented. We're always going to need a copy of their LDL lab. If they're a new start, generally we're going to want that between 30 and 90 days. That's what most insurances are going to be looking for. I know 30 days is probably a bit ridiculous, but it can be argued on appeal. But to be honest, it probably just takes less time to get another lab rather than arguing about how ridiculous that is. But as long as you've got at least a reasonably in-date lab, you'll be fine. If they're on samples, which I don't recommend, insurers don't care if the drug is working for the patient at all. I can tell you personally, because I worked at an insurance company, it makes absolutely no difference if the drug is helping the patient or not. All that matters is that they meet the criteria. So it really does not help at all. But if they're on samples, you'll want to include a lab of what their cholesterol is before they started it. If they have a recent lab showing that they have a much lower cholesterol, as long as that lab's within 30 days, it's fine as long as we have a prior lab showing what it was before they started. If it's a renewal, very often there won't even be a specific lab date. They just need documentation that the drug is helping them. It varies by insurer. I would recommend probably a lab within 6 to 12 months if possible. And of course, we'll want a copy of what the starting LDL was. If you don't have the actual lab, an approximation will do. The last important piece of documentation is the statin history. The patient is going to be in one of two states, either currently taking a statin or not taking a statin. If they're currently taking a statin, we're going to want to know the name of the statin and what the strength is. If they're not on a high intensity statin, but they are on the maximally tolerated dose, you will want to include that. Some insurers will require that they have tried and failed a high intensity statin or give a reason why they could not take a high intensity statin. If they're not taking a statin, we'll need to know why specifically they're not taking a statin. If they have a direct contraindication where they just cannot take a statin at all, maybe they have liver disease or a significant drug interaction, you'll want to specifically document that. If they're a statin intolerant patient, we're going to want to know which statins they've tried, and if you happen to know if they took the lowest FDA approved dose, you'll want to include that as well, as some insurers will ask if they tried the lowest possible dose. Lastly, we have other documentation that is less frequently asked for or less relevant. Starting with the diet and exercise statement, this is somewhat common in Medicaid plans. Honestly, mainly it's a tactic just to get people to give up on requests. Most EMRs actually these days will include a diet and exercise statement automatically for you on your consults, but this is a kind of documentation that I don't think it's worth changing your practices for. Whenever it happens that it's required, it's more time effective just to do it after the fact than to change your habits for every single patient. Lastly, other drugs. The only time this is going to be relevant is in two situations. If the patient specifically requires Repatha or Praluent because they had a side effect to the drug or it was not effective, or maybe they have a latex allergy, if they have a specific reason why they should have one or the other, you'll want to document that in the record. And the only other situation where it can be somewhat relevant is if the insurer asks for ezetimibe and they are somewhat close to their LDL goal. So if they're within 20%, then it's reasonable for them to try and fail ezetimibe. So if it's not too much trouble to include an ezetimibe statement, I would do it. But if not, to be honest, most cases, most doctors use good judgment. So if ezetimibe would get them to goal, they're going to give them ezetimibe. So most of the time when someone is not taking ezetimibe currently, it's usually a situation where their LDL is just way too high in order for a drug like that to get them to goal. And of course, most other drugs aside from ezetimibe have even a weaker cholesterol lowering effect, and they're even less frequently asked for, usually maybe 1 in 400 requests. So for those other drugs, I usually would recommend to not bother including that information. Thank you for watching. I will also put out another video on how to submit these requests through our website or by fax if you're interested. I will leave a link below. If anyone has any questions, feel free to reach out to us either by phone or by email or through your preferred contact method. Thanks again for watching, and we'll see you around.